Thank you both for your testimony. Mr. Topping or Ms. Seawright, does the potential, the described efforts by the VA in these new contracts meet the requirements that the Inspector General has recommended be included as parts of those contracts? Do we know that yet? Have you reviewed to see if their contracts are going to meet your requests, or your suggestions? And have you reviewed the suggestions to make sure your contracts are going to agree with them?
So we've done some preliminary reviews of the contract language or the performance work statement language, and it does have some good indications of that information. However, until these contracts are actually awarded and the negotiations are finalized, we're going to remain diligent in reviewing that information.
Diligence fine too. Diligence is fine. Mr. Topping, do you agree with the recommendations and intend to pursue them in the contract process?
Chairman, absolutely. IG's been a great partner in this. The recommendations, and there are about 98% of them that I fully agree with. We are working on implementing, and the rest of them will work it out. So absolutely good partnership. We are working on that together as we move forward.
Mr. Topping, an IG office last April issued a report about the Omaha VA Medical Center and found that the VA staff were limiting veterans' access to community care by manipulating clinically indicated dates in violation of the Mission Act. We've heard just this week, my office heard a similar allegation at another VA facility. And so I'm interested in knowing whether there's been any follow-up, but Mr. Topping, will you commit to looking into these allegations and quickly make a course correction as needed?
Yes, Mr. Chairman, we will.
I mean, I've had this sense for quite some time through numerous administrations that in fact, I think we've learned that it's true, that there was a concerted effort to discourage the use of community care. That discouragement came from VA officials and employees and affected the capability of veterans who qualify for community care to receive that community care. Do you know of what I speak, and do you know if there's a problem that exists, and has it been corrected or is going to be corrected?
I do, Mr. Chairman, and here's what we're doing about that. And so, as I said in my opening statement, VA is a direct care provider. That's our hospital and clinic system, and VA is a payer, and that's the community care program. These are different systems, different purposes, different tasks. What we have done in the past is combine management of these programs together. And what Secretary Collins has directed is that as an operational vertical, community care will be its own payer vertical within the VHA system. We will account for and manage the funding of that system independently of the direct care system, and there'll be leadership that is focused directly on community care. This will go a long way to remedying some of these confusion between what the role of a direct care provider is versus what a payer is, and ensuring that we can meet the requirements both of the program, the Mission Act, and anything else that Congress wants us to meet.
Mr. Topping, there are graphs, there are charts, there is allegations, I don't like that word, there is indications that the community care costs are rising more rapidly than the direct care costs. I would say that cost is, in my view, a misleading word. It could be more spending is occurring in one category over the other. But what I know about that is, first of all, the Mission Act allowed veterans to receive care if it was in their best interest to do so, determined by the veteran and his or her provider, not by the VA. And there were no artificial limitations on the amount of community care that could be provided in the Mission Act. So a number of categories by which one could receive care in the community, but one of them is it in the best interest of the veteran? And so I want to either confirm or indicate that I should be looking at additional ways of describing this, but there ought to be the opportunity to receive care if it's in that veteran's best interest. And the idea that we're spending more money, and again, I don't think spending is the right word, more veterans are choosing or being cared for in community care. I also want to point out, again, and you can correct me if I'm wrong, but what I know from information that I've seen that I believe to be accurate is the largest increases. In fact, As I understand it, there's been $26.7 billion increase in community care spending, FY 19 to 23, and that the largest components of that, number one is emergency care. So it's perhaps not even a decision made by the veteran. It may be where the ambulance service is taking a veteran, what's most proximate to his or her home, or where the injury or need for community care originates. And the second is geriatric and extended care. It caught my attention that extended care, which is in-home care for veterans, family members caring for them, is considered community care and included in those statistics about increasing spending on community care. And so it's really half of the increase in spending on community care has been emergency services and geriatric and extended care, care in the home for veterans. And part of that comes with the very bipartisan passage of the Elizabeth Dole Act, that it provides opportunities for that care to be increased. What am I missing here? How can I be corrected? I know that the Veterans Healthcare Administration is also here. Maybe this is a question for you, Ms. Gurud. But tell me the facts here that make sense when we have this discussion.
Mr. Chairman, I think everything you said was true, and I'd have sort of 3 points in response that help clarify that. Number one, there has been an increase in spending, but there's also been an increase in utilization. And those numbers that you see and that we show are not risk adjusted. So it doesn't show the type of care that we are purchasing. So we are purchasing more care for veterans in the community, and we are purchasing higher cost, higher value care for veterans in the community. I think that's number one. Number two, it's not necessarily a negative. It means that we are adjusting where veterans receive care to ensure that we are meeting their needs, including locally, not just within the VA system. And I think the last point to that too is those numbers taken in a vacuum sort of belie the overall VA spending. And so while we talk about this being a 10-year trillion-dollar contract that it is, over that same period, we're going to spend $2 trillion on direct care. So this is one piece of the overall continuum of care. These work together to ensure that veterans receive the care that they need, where they need it, when they need it. And so making sure that we are accountable for that is a different task than whether or not those numbers are right or wrong. And the last point on this too is the intention of the Community Care Next Gen program is to give VA the tools to manage the quality of care so that we know what we are getting and it's the best possible quality of care for our veterans, and for us to be able to manage the cost to be responsible for that. So the tools that we need to manage this program are included in Next Gen so that we can be responsive to these concerns and questions.
Thank you for your answer. I'm going to turn to Senator Blumenthal, but I would indicate that I share the concerns about what we've seen in an Inspector General's report about quality, about medical records. There needs to be improvements that I believe your efforts here are designed to achieve in community care. It's not that it doesn't have its faults and challenges, and we need the VA to be watchful in regard to providing care in the community to veterans. Senator Blumenthal.